Okay, off we go. So thank you all so much for having me here. This is really a fun opportunity. Thank you, Alyssa, for inviting me. And it's really a treat to connect with you all over the world. I'm going to be talking today about the integrated approach to providing psychological and more broadly psychosocial care to our oncology patients here at St. Jude. So, of course, our programs rely very heavily on guidance from our beloved standards for psychosocial care, which I will review and reflect on throughout our time together this morning or this evening or in the middle of the night, as it is for some. Before we begin, I want to confess that I'm not super familiar with my audience today. I can read in the chat if anyone wants to type in maybe briefly what discipline you represent, just so I can get a sense of, what kinds of providers I'm speaking with today. That might help us make this a little more personal or individualized. Let's see, I need to advance. Okay, I don't have any conflicts of interest to disclose. And what we're going to do over the next hour is I'm going to share an overview of our integrated psychological and, again, psychosocial service model here at St. Jude, including our application of universal educational interventions for our newly diagnosed pediatric oncology patients. Thank you all who are typing in. I appreciate it. Oh, lifelong nurse. I love it. So quickly, I want to review the role of psychology, which I am a psychologist, in pediatric cancer. And again, more broadly, most of us are from psychology. Thank you very much. That's helpful. And then a little bit more broadly across other psychosocial disciplines and types of support. So, as I'm sure all of you know, our patients adjust remarkably well. Research has long documented that not only is there an absence of psychopathology in our active therapy patients, but in many cases, there are lower levels of psychological symptoms such as depression in our pediatric oncology patients versus their healthy peers. A lot of this, aspiring oncologist, I see, chief nurse. Okay, this is great. Thank you all so much. And a lot of this work was done here at St. Jude and in collaboration with my mentor, Sean Phipps. So if we all can sort of agree that our patients are remarkably resilient and in general, they respond generally well, psychologically speaking, to the cancer experience, why is psychological and why are other types of psychosocial interventions so important? I think that we can all agree that pediatric cancer patients and their families experience significant stressors throughout their cancer experience. And as psychosocial and medical health care providers, we can probably also agree that intervention isn't just for patients with psychopathology. We're not here just to treat psychopathology. We're here to improve quality of life throughout this very difficult experience. So here we see sort of the ideal trajectory for pediatric cancer. And we know that there are disease and treatment milestones that are likely to bring increases in stress to families. And we believe that these represent ideal times to increase psychosocial support to facilitate coping for optimal adjustment for these kids. So the most obvious of these times is the time of diagnosis. During this time, children are sick. The families are learning about the disease, the treatment, the prognosis, plans are being made, and most commonly, we see an acute increase in distress. Then treatment begins. Patients and families adjust in many ways to the treatment plan. They're resilient. They're maybe doing better at this point, but they continue to encounter new challenges, side effects of treatment, distress from needle sticks and other invasive procedures. Some patients are at risk for non-adherence to treatment. There might be social isolation and other things, uncertainty that could have negative impact on mood and, again, overall quality of life. And again, most patients start adjusting well. Many are able to cope very effectively throughout their treatment, but the transition off of active pediatric cancer treatment can be met with mixed emotions. Patients and caregivers often report that they are both excited about and relieved about the completion of treatment and cure, but also a lot of uncertainty and anxiety around the future and what the future might hold for them. And even into survivorship, we know that our survivors remain at increased risk for numerous negative health experiences. So even then, there's a role for psychology, psychosocial intervention in facilitating, for example, the modification of risky health behaviors to minimize the chance for second malignancies. Also managing things like survivor's guilt, and again, just transition back into life and being a productive, healthy person. So again, most patients and families adjust well over time. But what if they don't? Or perhaps more importantly, what if we can intervene prophylactically to prevent some of the distress, prevent some of the non-adherence, prevent some of, or at least minimize some of these potential negative outcomes or experiences? We're going to spend a few moments reviewing the standards for psychosocial care for children with cancer and their families. So again, unclear here with my audience. I'm not sure how familiar you all are with the standards. So I'm going to briefly review them, and we'll be referring back to them throughout our time together today. So since back in 2015, Pediatric Blood and Cancer, the 15 standards for psychosocial care for children with cancer and their families. And I see Dr. Lori Weiner has just joined us. Hi, Lori. I'm happy to have you here. As I'm citing her work, Lori and her colleagues really defined the blueprint for psychosocial care for these patients, and everything listed in the standards is designed to mitigate the negative psychosocial impact of cancer and ultimately improve not just psychosocial, but the medical outcomes. So briefly, let's run through these. The standards are systematic psychosocial assessment for patients and families throughout the course of their treatment, their cancer journey. Neuropsychological screening for patients with CNS disease and treatment so that we can monitor for cognitive weaknesses. In survivorship, it is important that we continue to screen our long-term survivors for educational needs, anxiety, depression, risky health behaviors, other things. The fourth standard, intervention and support. Our patients and families need access to psychosocial intervention throughout the cancer trajectory. 5, this is important, and for a lot of our families, there's a lot of financial burden and risk for financial hardship associated with care for cancer. 6, caregivers. Caregivers need support. They need assessment of their mental health needs. They need access to intervention. If they aren't at their best, in their best mental health, their best health state, they can't be the best parent for their child as they go through cancer treatment. Standard 7 recognizes the importance of anticipatory guidance and psychoeducation regarding disease, treatment, acute and long-term effects, hospitalization procedures, etc. Speaking of procedures, Standard 8 recognizes that patients should receive developmentally appropriate information in preparation for medical procedures. Social interaction is very important for our patients at all ages, and they should be provided with opportunities for social interaction during treatment and into survivorship. Siblings are a very important part of the family system, and we know they are also at risk for psychosocial difficulties and thus should be provided with supportive services. Academic continuity. Most of our patients, their job before they're diagnosed is to go to school, and it's really important that we keep them connected educationally, academically during their treatment, and then facilitate reentry support at the time of completion of therapy. Medication adherence. obviously hugely important to the medical outcomes here, and we need to be assessing adherence routinely and monitoring it throughout treatment. Palliative care. Families should be introduced to palliative care early in the cancer experience with the goal of reducing suffering throughout the treatment. And again, this is regardless of status. Bereavement follow-up. When we do lose patients, it is very important that we continue to work to contact these families to provide bereavement support resources and services. And the 15th standard, overarching the importance of communication among the medical and psychosocial providers and with the families. It's important that we're open, respectful. None of this will be shocking. I'm sure no one will disagree with this. So again, we're going to be referring back to these throughout our time. And thinking about my role as a psychologist and the 15 standards, I can see a role for psychology potentially in monitoring, delivering, implementing any one of these standards. However, there are numerous psychosocial and medical disciplines that can, and I'm sure do, address a number of these needs and help to ensure the highest possible standard of care is met. So, for example, psychosocial assessment, standard 1. This may be completed by basically anyone on the psychosocial care team, and I'm sure many medical providers can facilitate assessment of these needs as well. And a bit later, I'm going to discuss the overlap or potential overlap in scope of care across providers and how to maximize the role and impact of each one. So first, let's talk about the importance of psychological care being integrated into the patient's cancer treatment and the family's overall cancer experience. And I want to illustrate this, with the story of psychology services at St. Jude. Historically, my psychology clinic here at St. Jude, we were a consult service. So patients were referred to us based on the medical team's identification of needs. Now, this is a good start. However, medical providers are not necessarily trained to identify psychological and other psychosocial needs. And we also know that this process is very vulnerable to provider bias. We noticed that some of our physicians and nurses were referring lots of patients, and others we never got any referrals from. So a little bit of a concern there. And a lot of times we were consulted appropriately, but not until after a patient had already suffered quite a bit. So in general, we felt like we were providing excellent services to individuals who were referred to us, but we were really worried that we were missing many patients who could have benefited or could have benefited sooner. So we believe we can do better. We can do better. And we set out to standardize our practice. We created an integrated model of care, seeing every patient, not relying on referrals, and then going from there to sort of fill existing gaps in services. And one of the guiding principles for us was to ensure equal access to psychology and psychosocial services for all of our patients. So in particular, we focused on developing a universal care model to prevent or minimize psychological distress prophylactically. So to facilitate coping and adjustment during the treatment milestones that we know to be particularly challenging for families. And this involved establishing programs to allow for all of our patients to be seen at diagnosis and as they approach the end of treatment. And importantly, as relevant, patients are still seen at other times of medical significance or just by referral only. We are also very mindful to take a developmental approach to assessment, intervention, support services. My favorite example of this is our interdisciplinary early childhood clinic, which was developed to address the unique needs of our very youngest patients. Here you see my colleagues, Drs. Harmon and Molnar, who created our early childhood clinic, here with a young patient and his mother. And these developmentally tailored services are particularly important both because of the impact of the cancer experience on early childhood development, and because, as we know, half of our newly diagnosed patients are under 5 or 6 years of age. And I wish I had more time to talk about this, but this was sort of a little teaser for you guys. So back to the development of our integrated model here at St. Jude. We use Dr. Ann Kazak's Pediatric Psychosocial Preventative Health Model, PPPHM. This is a biopsychosocial framework for assessing and treating families of children in pediatric healthcare settings. And as you can see, it's a tiered model, the goal of which is to match the level of support or intervention to each individual family's needs. So simply put, to provide right-sized care. You can see here the 3 tiers: universal care. This is providing support, screening for indicators of higher risk, providing psychoeducation, anticipatory guidance for all of our patients. Then as needed, moving up the tiers. Some patients who are experiencing acute distress, maybe we identify risk factors. This is at the targeted level, and we're going to provide intervention and services specific to those symptoms, and then we're going to continue to monitor the distress that they might experience. And at the top of the pyramid, we see our clinical or our treatment group. And these are patients and families who are experiencing persistent or escalating distress, or we see a lot of high-risk factors. And this is when the psychologist is really going to be involved more intensely, more directly. And beyond that, these are the families that are sort of the all hands on deck situations where we're going to want everyone from the psychosocial care team involved. So let's begin with our universal level tier of care. All patients seen by psychology at these specific disease milestones are assessed, and this assessment helps determine the need for services, the goals of which are to provide psychoeducation and anticipatory guidance that will facilitate positive coping, to identify and enhance protective factors. So we're not just looking for pathology, we're looking for all of the resilience and all of the strengths that families bring into this experience so that we can help grow that and enhance that. And we're also working to identify, hopefully early on, any risk factors that are present so that we can develop more individualized intervention. A reminder of our specific disease milestones here. The 2 milestones at which we are currently seeing everyone is at the start of treatment through our new patient program, and as they approach the end of treatment through our transition program. And I want to mention that this universal model is still fairly new for us. We only finished full implementation in all of our oncology clinics about 1 year ago. This schematic shows you sort of the patient experience, the patient flow as they move through their treatment. So at each of the 2 time points, diagnosis and end of treatment, patients complete a 2-visit service with psychology. One is a health and behavior consult, which I'll talk about in more depth in a moment. And the other is a brief cognitive academic assessment. And you can follow the arrows here to see the expected movement from new patient through treatment into preparation for transition, and then again, the 2 visits. And at both of these touch points, the results from our health and behavior and our cognitive assessments are used to design individualized plans for each patient, each family. Importantly, again, the universal service that everyone receives, so sort of shown here in bold, it's a little bit difficult to see, involves psychoeducation and anticipatory guidance. Now, additional services based on individual needs might include psychological intervention for specific concern. For example, non-pharmacological pain management, treatment of procedural distress, mood concerns, significant anxiety. But it also involves a lot of referrals to our other psychosocial service providers. And it's at these touch points that we're making the determination if a patient and a family should move up the tiers in Kazak's tiered model. So is universal adequate, or do we need to be providing more targeted or even more intensive care at for example, the clinical level. So the goals of our health and behavior assessment, this is one of the 2 visits at each of these time points, are we're consulting, interviewing the patient, the caregiver, the family. Again, we're identifying strengths. We're also working to identify areas where they might need a little bit more help. And although we don't see it as commonly as we see other just areas of distress, we do screen for the presence of significant psychopathology. A little more information on some of the topics we're exploring with our patients and families during this consultation piece. We're particularly at the new diagnosis time point, we're sort of assessing for their understanding of diagnosis and required treatment. How are they coping so far? What kinds of coping strategies has the family used effectively in the past when they've dealt with stressors? Again, so we can help grow these strengths to encounter this new challenge. We're asking about adherence, whether that's can they swallow pills, other things related. We're spending a lot of time talking about pain, other physical symptoms. We're talking about sleep. We're talking about diet, appetite, sort of all of the health behaviors that we know to be important during treatment. And we're really also trying to set them up for success in survivorship as well. Also during this visit, the patient, if they're 8 or older and the caregiver completes some symptom inventories for us, it takes maximum of 10 minutes. And one is, I'm going to show you a screenshot of the Speedy. And this measure goes down to age 8 currently, although they're currently validating a mini Speedy. How cute is that for even younger children? Self-report and parent proxy report. And importantly, and I've got the QR code here for you guys if you want to snatch it. These measures are available for free download in English, French, and Spanish. And this is the Speedy is asking about common symptoms in pediatric patients, physical symptoms, and some emotional and behavioral symptoms as well. We also administer some select age-appropriate surveys from the PROMISE measures. This is a library of self and proxy report PRO surveys developed by the NIH here in the US. And again, importantly, we're screening for psychological and somatic symptoms, but we're also seeking to identify strengths in our patients and our families. So we're asking about positive affect. Have you been happy this week? What have you enjoyed? Things like this. And again, we use our findings from this assessment to develop individualized plans for support and intervention based on the tier. So at the universal tier, again, everyone is going to get some kind of intervention. So if patient and family are coping well and have no clear needs, we're still going to provide them with anticipatory guidance and psychoeducation. We're going to remain available. We're going to say, let us know if things change, and we're going to plan to see them at the next important disease milestone if we don't see them any sooner than that. If during our assessment specific needs are identified, we're going to use some targeted interventions. So maybe pill swallowing training, maybe introducing non-pharmacological pain management, maybe behavioral sleep intervention, things like this. Give me. And then at the clinical level, we're gonna sort of need to rely on some more involved psychological and psychosocial interventions. So some examples, these patients who really need more attention, more intervention from us: cognitive behavioral therapy for persistent mood disturbance or anxiety, perhaps motivational interviewing to improve adherence. And again, we're going to be collaborating across the psychosocial and medical teams. I want to acknowledge that this is a very resource-heavy model, and even at our very resource-rich institution, it is a bit of a stretch for us to make this happen. We are banking on our belief that early identification and intervention is going to result in fewer patient needs at the clinical level. And I do not yet have data to support this, but I can tell you anecdotally, we are feeling like this was a good call. And we are feeling like the more we are providing preventative prophylactic services, the fewer sort of reactive consults, emergency situations we're getting ourselves into here. So again, at least anecdotally, I can tell you we're feeling really good about this. And again, this is still new, and we are eager to measure the impact of our services, and in particular think about things like should we develop guidelines for sort of thresholds for service at each of these tiers. We're also curious about other disease milestones we should be looking at. Going back to the patient flow through our standardized touch points that I showed you, I want to focus in on the potential outcomes or services that come from our initial psychological assessment. So zooming in here, referral to psychosocial services. This is really important. Psychologists work very closely here with our other services, which is a great segue to our next topic. We're going to briefly talk about the scope of psychosocial care, and more specifically, how the oftentimes overlapping roles of psychosocial disciplines makes it important for us to clarify the roles so we can maximize and optimize care to the patient. So earlier, when we reviewed our psychosocial standards, we acknowledged that there are often more than one discipline that might address each of the standards. Again, thank you all for sharing in the chat sort of what some of the disciplines we have here are represented. I work most closely in my practice with social workers, child life specialists, chaplains, teachers and school advocate liaisons, psychiatrists, and then of course, members of the oncology team in particular. And we all have roles, and again, roles that might overlap. And a quick reminder of Standard 15, and in particular, the element of overlapping roles here. This is really important to acknowledge and to be mindful of and intentional about when we are providing services to our patients and families. So several years ago, we at St. Jude identified a pretty significant challenge in our work. The unique disciplines providing psychosocial care to our patients and families were not effectively integrating. And this caused a lot of problems. There was some lack of understanding of our roles across disciplines. And again, the shared scope, while sometimes appropriate and sometimes overlap is appropriate, at other times it can lead to duplication of services, which is very wasteful. It can lead to gaps in services if we're making assumptions about what each other are doing for our patients. At times, it can create staff conflict, and perhaps most concerning to me, at times it can create patient confusion. Oh, well, I was working on relaxation or non-pharmacological pain management with my social worker. Well, my psychologist does this in a different way with me. Importantly, there's plenty of work to go around, as we all know. And so developing a shared understanding, we believed, was really essential to maximizing our care. So we set out to define and clarify the scope for each of our disciplines, developing a common understanding of our roles, identifying shared versus discipline-specific areas of practice, and again, with the goals of decreasing duplication, decreasing gaps. And this also served to clarify when we needed to address the need of a patient. When is it my job versus when do I refer out to another discipline? And then when do we need to collaborate, which we know is often the case. So just to tell you a bit about our process, each of the disciplines involved generated a list of clinical activities that fell within our scope. We defined each, being really careful to ensure we were using the same language and defining a service or an intervention in the same way. We identified overlap and discussed if that overlap was appropriate or if it belonged more solidly to one discipline versus another. And then each discipline rated each of these clinical activities as to whether or not this is within their scope and to what extent. And then we reached a consensus eventually through discussion. Our final product is a reference resource that clearly defines the scope for each discipline. There is a grid like this one that you see here. This is psychology's, mine, that I'm sharing with you. And you can see that each of the clinical services included here is rated as solidly within the scope for, so the highlighted column you see is a 2. This means these services are solidly within my scope as a psychologist. And in some cases, those services are unique to psychology. So for example, neuropsychological assessment, that's pretty unique to our discipline. Others are less unique to psychology, such as consulting with schools or more general counseling, family support services. At the end of this process, we really appreciated a number of positive outcomes: increased understanding of what each other do. Again, as I mentioned, a shared language. This tool, this matrix, this grid serving as a tool for new hires, trainees in our group, and our medical teams, so they know who to consult with, how we can help. Now, we also have this as a tool for occasional disagreement. I mentioned we used to have more staff conflict around some of these areas, but now that we have really developed this shared understanding, this is very rare, which is really exciting. We also have integrated more efficiently, more effectively with each other. We feel confident that we're providing more comprehensive psychosocial care. There are fewer gaps in services, less duplication of services, and this has led to increased provider satisfaction. I can be a psychologist and not feel compelled to also do the work that might fall or best be served by other disciplines. And this benefits our patients because they can benefit from the unique experience that each of us bring. And I just want to give a shout out to the incredible interdisciplinary team who worked on this with me. Now I want to move a little bit back to our model at St. Jude, and in particular, the educational interventions that we offer as part of our universal care model. Again, this bottom tier that everyone receives. So again, another reminder, Standard 7 reminds us of the importance of the provision of psychoeducation and anticipatory guidance. So anticipatory guidance, meaning to communicate what to expect to our patients and to our families, and psychoeducation to empower and promote coping, promote decision-making. These educational interventions are consistently rated as highly acceptable by patients and caregivers. And importantly, they're also relatively low cost. They're very highly portable. They are often available electronically. And by offering these interventions, we're able to decrease uncertainty, confusion, surprise. We're also able to decrease anxiety and distress. And we know that this ultimately promotes the adjustment. Again, in particular at these times of increased distress, diagnosis, changes in treatment, preparing for transition off of therapy. So to facilitate our provision of this standard of care, we've developed a number of patient education materials. They are available in print, as you see here, and some of them, actually probably most of them now, are available electronically. I'm going to share the QR code with you guys here, and so be prepared to snatch it up. These in particular that I'm showing you are utilized during our new patient visits, provides a lot of information about some of the areas that we see families struggle with the most in the early phases of their cancer diagnosis and treatment. And I want to mention not just that we see, that implies that we, the providers, find ourselves to be expert in what the patients and families are experiencing and need, and that is not fair at all. Rather, we've worked very closely with our Patient and Family Advisory Council over the years, seeking input, having focus group, having conversations, completing surveys with what is it that they have struggled with the most. And my favorite question to ask is, what do you wish we would have told you at the beginning of treatment. And that's what a lot of these materials are all about. And importantly, there are 3 primary developmental stages. Here's the QR code for you guys if you're interested. We sort of developed these materials separately for young children, school-age children, and then our teens and young adults. And here you can see the topics that are covered in each of the materials. The team that worked on these, again, wanted to create something that would be meaningful and relevant for all families, some things that are universal. So again, asking the question, what do you wish we had told you at the beginning? And that's what a lot of these topics came from. When we hear all the time is that families wish we had talked to them about sort of the importance of maintaining boundaries, maintaining behavioral expectations, maintaining healthy sleep routines, maintaining social connection to peers, things like this. And here's an example of what these printed materials look like when you open them up. So beautiful, colorful, really nice graphics. The information is provided in simple bulleted format. All of them include QR codes and websites to take you to more detailed information, and also how to ask for more help, how to get connected to a psychologist or another member of the psychosocial services team. We've developed some similar educational materials to facilitate preparation for the transition off therapy. Again, another one of these times of increased distress and mixed emotions, and addressing topics such as social reintegration, as you see here. And again, taking a developmental lens and consistent with our standard, what is it? Standard 10 is for siblings, I think. How to support siblings during this transition as well. I want to give a quick plug for an incredible resource, together.stjude.org. I hope you all are familiar. If you're not, please, please, please check it out. This site is a one-stop shop for families facing pediatric cancer. And in fact, we're expanding to other catastrophic pediatric illnesses as well. So you might find information relevant for other patients you might encounter depending on your setting. If you go Dr. Weiner, I love your question. There's a lot of great content here, medical content, but also quite a bit of psychosocial care content. And again, the universal education materials I've shown you here are available. And importantly, because part of St. Jude's mission is to improve the lives of children with cancer and their families all over the globe, the site has been translated into 11 languages. Please check it out again if you haven't already. And also my email address is here. I'm happy to share anything with you. I cannot promise you that all of the materials relevant to psychosocial support and intervention are translated into all of these languages. Obviously, it's very complicated. Not only are we translating, but we're trying to, I say we, I'm not part of the team working on this. The Together team is also working to make these materials more culturally relevant to each of the cultures that speak these languages. And it's, as you might imagine, very, very time intense, but we're working on it. We're getting there. So let's briefly touch on a few of the sort of future directions for us and our ongoing work to integrate and provide maximum services to our patients. Several years ago, we at St. Jude evaluated ourselves using the Pediatric Psychosocial Standard Institutional Assessment Tool developed by Dr. Weiner and colleagues, and also known as the Matrix, which I love. So this tool was designed to help an institution assess how they're doing in terms of delivering, implementing care consistent with each of the standards. So here you can see a snippet regarding the standard 1, regarding psychosocial assessment. And for each one, Again, developed in this, it really truly is a matrix. The standard is listed, domains and essential elements within each of the standards, and then a 1 to 5 rating scale with some really good, Lori, you guys did a great job, anchoring some concrete anchors for each of these so that it's really very user-friendly to evaluate yourselves. And, we do this, we are seeking help, input from a lot of raters. We are, of course, rating ourselves. We're partnering with our physicians, our nurses, others that we work with, help us rate ourselves. And again, we did this, completed the matrix a couple of years ago. It helped us think through areas of improvement, but we plan to engage in this again and to reevaluate again, with a goal of identifying additional areas for improvement. And once areas for improvement are identified, so again, like an area where we're not currently meeting the sort of essential elements of care to score a 5, the top score, then we can start doing the work. So the guidelines are a second implementation tool published by the same group. And the guidelines are quite simply a tool designed to help institutions improve their implementation, again, their score for each of the standards. And again, these tools are very user-friendly, available free and easy. Here's the citation. I would encourage anyone seeking to implement psychosocial care consistent with these standards to take the time to evaluate your institution and explore the guidelines for some really helpful resources for improving your score. Let's see, there is any assessment form for patients and parents that includes answers. This is a great question. I believe, Maria, that you're asking about how patients and families rate us on our delivery of the standards, which I do want to mention very briefly. But first, as we're preparing to reevaluate ourselves and to return to the guidelines to improve our services, we're also working to begin assessing the impact of our integrated model of care and exploring results of a recent caregiver survey that we sent out, again, in partnership with our Patient and Family Advisory Council. So we're really excited about that. We're also working to leverage our new electronic health record to hopefully allow us to monitor outcomes a little bit better. So at the individual patient and family level, but also we want to start empirically exploring the impact of our programs. And our approach is one of constant improvement. We want to constantly be refining the interventions and the services we're providing to best support our families throughout the cancer experience. And as I've sort of hinted at, one way we do this is through the inclusion of the family voice. Again, family surveys, and in collaboration with our Patient and Family Advisory Council and Dr. Weiner, again, here with us now. I'm really eager for forthcoming results of a research project that she has currently underway. ISTEP, I believe, is the acronym. She always has really good acronyms for her work. That is exploring, among other things, they're sort of exploring what are families' perceptions of which of the standards should be prioritized, which I think will be very, very informative and helpful, again, in conjunction with self-evaluation using the matrix and the guidelines, sort of really where should we be putting our resources? What do families think is the most important for them? So thank you all. I'm going to look in the chat to see what kinds of questions I might have missed. And I'm also going to open the floor. I think we have a few minutes for questions. So again, let's see, Maria asks, is there an assessment form for patients and parents that include answers to the 15 standards? Maria, are you asking about families assessing the delivery of the implementation of the standards? Are you asking about which standards each individual family might want the most assessment with? And depending on your question, maybe Dr. Weiner can help us answer this. Maybe you're typing. Both. Okay, both. So Dr. Weiner, I hate to put you on the spot, but are you willing to tell us a little bit about your current work and your survey and focus group work to explore this with patients and families?
Sure, and beautiful talk, and thank you for all those unnecessary shout-outs. So I think what's happened is many sites have created their own tool so that they provide the wording of each of the standards in words that families would resonate with. So standards and psychosocial, some things are just defined in terms of the social and the emotional or the practical or the spiritual care of your child. And then they have done it in more in terms of a needs assessment, or just to be able to list out what the standard is, again, in the language defined in words that the families would resonate with, and then to ask him if they feel like it's being provided to their child. And being able to get that feedback has been really, really instrumental. We haven't looked at all the data yet. We have over 200 families, actually about 270 families at this point, that have completed this part of the survey across the United States. So we will really learn to see what their perceptions are about the different standards being implemented or being provided to their child and to themselves. I think an important part is that we'll have to be able to look at the time frame of when they answer the questions, because if somebody is newly diagnosed, they may not have received all these services. Of course, that's going to look very different for a bereaved family that were included in this cohort, because they are now looking back retrospectively to be able to see and to be able to report on what they and their child has received. And just as a reminder, as Niki has talked about, is just there is a bereavement standard, which is a pretty low bar of the services that should be provided. So I don't know if that answers your question. I think it does depend on culture, and it does, obviously, language is important, but I highly recommend that you define each of the standards again in the words that the families will use, and I engage families to help you. We've engaged families to help us to be able to define each of the standards so we could really make sure that it is being provided and explained in words that they understand. I hope that answered that question, and thank you.
Thank you so much, Lori. And in the chat, Viviana, I hope I'm saying your name appropriately, is sharing with us that she's a psycho-oncologist and clinical health psychologist who's coordinating the psychosocial project in Latin America for the Global Initiative of Childhood Cancer. She's basing her work on the psychosocial standards and PSYOP psychosocial recommendations to develop a proposal adjusted to their reality. She would be happy to share and discuss their findings and next steps, which we love, hoping to improve and strengthen. That's awesome. Share, hop on if you want to share. You want to say anything?
Hi.
Hi.
How are you? Yeah. Well, hi, Lori. We recently met. Yeah, I can give you the article we published recently. We are currently working as a participative project in Latin America and Caribbean, based on the psychosocial standard, but adapted a new proposal from 6 standards. So I can give you the information we've been working, and I would love to to share more. We are currently making a survey for professionals in the region about psychosocial care. So when we have the findings, I hope to share it with you and discuss the next step. We want to implement them based in our resources, our strength, but also we want to work improving the opportunities psychosocial workers have in our institutions.
I
Thank you
will
so much
react
for
to
sharing.
Viviana's statement. Thank you, Viviana. I'm sure your experience will be very valuable for the group. So maybe later we'll discuss, because this is the psychosocial working group, a platform for sharing this experience. So we'll discuss, and maybe in the future webinars, you will have the floor to present deeply your experience.
Thank you very much.
Thank you.
Other comments, other discussion? Are there things I can share with you all?
It seems there is another question from Catherine.
Let's see. Lost sight of the chat here. Should we need to consider how we provide psychosocial care to families who experience cancer diagnosis of the child survivor of cancer? Catherine, it looks like you are unmuting yourself. You want to ask? Speak.
I didn't know if we. Yeah, it was a recent experience. I was contacted by the mother of a child I treated in the 1980s with ALL.
Wow.
And she searched me out, and I have a new last name, but she was able to find me, and she emailed me at my work email address, and his recurrence was his original ALL.
Oh, wow.
That long ago. And so, this is a man married with 4 children of his own. And it's sort of like, well, what do you do? And the 2 people he wanted to talk to first was his teacher that he had when he was diagnosed, and his oncologist. And then they reached out to the nurse. It was just like, it was pretty extraordinary, but it's like, okay, what are our, and I told this mom, I will not provide professional recommendations, but I'll hook you up with people who can, you can reach out to. But it's something to think about,
It is. And that's so tough for so many reasons. The difference, just medically speaking, between treating a child and treating an adult. And also, I'll say, as a psychologist, I really am only a pediatric psychologist. I wouldn't know how to help an adult really either. Lori's right. This speaks to the powerful relationship that you had. I think a lot of times we don't know the impact that we have on these kids and on their families. Things that might be very small to us might be very big to them. Catherine, similarly, I've been at St. Jude now for almost 19 years, and I had a patient stop by clinic. She was a teenager when she was treated. She is now in her mid-30s, has children, works, and she's a LPN, a nurse. And it's been 15 years since I've laid eyes on her, and she's here for a research study and came and asked, I want to talk to Dr. Niki. And it just blew me away. Like, how do you even remember that? Why me? So it's amazing.
Yep. And it's, thinking about our professional boundaries. And that's why I said, I'm not going to be, I can't be your nurse. I can't make care recommendations, but I can hook you up with people who you can. And he's being treated at the same hospital he was originally treated at.
Oh, wow.
Yep.
That's something. I'm seeing a question here from Julia. What about when there's no psychologists, psychosocial providers available? How do you measure distress? What do we do with this? This is a good question. And one I'll confess I haven't had to face. You're mentioning the PAT. That's, I know, used in a lot of institutions. Also, a lot of times a very simple measure of distress, a distress thermometer, is something that's maybe even easier, showing a visual analog scale of, 0 to 10, and how asking a patient or asking a parent, how distressed are you? How much stress are you experiencing currently? And again, to your point, it's short, it's quick, there's no training to use. Anyone else have other ideas or suggestions? And then, of course, if you have no psychosocial providers and you do measure distress and identify distress, then what do you do with it? Go ahead, Laurie, please.
Yeah, really important point, because you don't want to ask about certain areas of psychosocial distress and then not do anything with that information that they now personally shared. That doesn't feel very responsible, but one of the steps before that is to ask the families that are coming in what their psychosocial needs are, and then to be able to go to, administration or foundations or something to be able to say, this is what they've identified as what they would like to be able to have that they think could be helpful to their patient, to themselves or to their families, and start there. I just always get concerned when we're asking about something that we can't be able to provide, if they even tell us that these are the issues that are going on for them.
Right.
Doesn't mean you shouldn't. I mean, it's really important. You don't want to be respond only to crises. You want to be able to be proactive, but being able to have them identify what their greatest needs are can help you then to be able to see where do I need to get those first resources.
And sometimes distress comes from things that could be addressed by individuals who are not necessarily psychosocial providers. Sometimes there are things that you as a nurse, for example, can do to help to support. A lot of times, some of the benefit from the anticipatory guidance and psychoeducation is sort of just validating some of the experiences that these families are having, and sometimes just being a validating presence can be therapeutic. We're at time. Thank you, everybody, so much. Please, please, please feel free to reach out, email me. Alyssa, what else do we need to do to wrap this up?
Thank you so much for this great presentation and for attendees to be so actively engaged in the webinar.
Thank you.
Thank you, everybody.
Okay, everybody take care. Great hearing from you all from all over the world. In New Zealand, go back to bed now, please. Bye-bye.
Thank you so much, Niki. It was a great
Thank
presentation.
you.
Thank you.